something which is coming up. Yeah, now I think it's. Yeah. Okay. Thank you, Navid. Thank you, Satyajit, and thank you, Mukesh, for organizing this wonderful webinar. It's a small presentation about acute bony Bankart repair. I'll tell you a technique of doing an acute bony Bankart repair. You see, whenever as we were discussing in younger individual patients coming with high energy trauma, usually often also have a bone loss. And whenever there is a significant bone loss, which is essentially due to traumatic lesions, this is a bony Bankart. And when you have a bony Bankart, these are the patients where there are high incidence of recurrent instabilities. And we need to find solutions to treat this bone piece and attach it back to the place from where it got detached. That's a small video how a bony Bankart looks like. Viewing from the posterior portal, that's an acutely injured knee. CT and X-rays, a young individual, 18-year-old, just show that there is damage in the anterior part of the labrum. Humeral lead seems to be good except for an acute Hill-Sachs lesion, which is right here. And there is some blood clot still there in the Hill-Sachs lesion. So that's a deep depression there. And you have a labrum tear in the front. Probably a bone piece as well can be seen here, and you can detect it by putting a probe there. Better to shift our telescope to the anterior superior portal, because viewing of the bone piece and its attachment from anterior superior portal is much more better. So we are shifting our scope to the anterior superior portal. And here you have a fracture of the glenoid base at the lower part. That's a bone piece with attached inferior glenohumeral ligament. So you can see the glenohumeral ligament is attached. And that's an acute bony Bankart, which is there, a bone piece which is there. And significant amount of bone is actually there. It's comminuted. It has got one or more than one piece. And there is a lot of damage to the cartilage on the face of the glenoid as well. So that's the bony piece, and that's how inferior glenohumeral ligament is attached to this bony piece. These patients need arthroscopy surgery to bring this fragment back, because if it is not done, there are huge chances of recurrent instability. There are special modifications in the technique, and I'm just going to show it by an animation. That's a glenoid and that's a bone fragment, and we can show it on another view as well, that this is how the glenoid looks like as a face, and this is the bony fragment. I usually use 5 anchors. So this is the first anchor, and I put it actually at the neck of the glenoid here. So my first anchor is at the neck of the glenoid, and it is going through the capsular tissue around the bony Bankart fragment. So that's the first anchor, which has a double loaded anchor, and the threads are going around the bony Bankart. That's the first one. The second anchor is just below where the lesion is there. It's like a normal Bankart repair where I would pull the capsule and stitch it down. The third anchor will be at superior border of the bony Bankart, and I will stitch it the way I stitch. And the fourth anchor is pulling the thread, and then it's like a push lock anchor, which is on the face of the glenoid, and we put it at the face of the glenoid like this. It actually compresses the fragment back. And the fifth anchor is also taking those threads which were through the capsule, and that's how it comes onto the face of the glenoid. And all of these tissues, when they are brought like this, is something like a double row repair. You are able to compress this bony fragment into the place from where it originated. So just by an animation showing how exactly the anchor placement and technique modifications are done so as to achieve an anatomical reduction of a bony fragment. We realized that putting a lower and an upper stitch first would help us in orienting the fragment right at the place from where it is detached. Number two, it does not allow the fragment to stick in a mal-rotated position. Just a video presentation now of exactly what I showed on the animation. Viewing from the posterior portal, you can see that's a bony lesion there. That's a bone Bankart with inferior glenohumeral ligament attached. We prepare the fracture area from where the acute bony Bankart has happened. Shift our scope to the anterior superior portal. Prepare the neck of the glenoid. So I'm coming from anterior inferior portal. Switching stick is still in the posterior portal, and we are viewing from the anterior superior portal. And from the front, from the anterior inferior portal, once we have prepared the neck of the glenoid, that's our first anchor, which is placed in the neck of the glenoid. Now, depending upon the length of the bony fragment, I might put 1 or maybe sometimes even 2 anchors here at the neck of the glenoid. So that's the first anchor which is being placed at the neck of the glenoid. It's a double loaded anchor. It has got a green and a white thread. And as I take the handle out, these are threads which are holding well onto the neck of the glenoid. Now, as I told you in the animation as well, my first step is to pass the sutures through below this fragment. So I'm taking a big bite of with a 45-degree suture passer, and that's a nitinol loop which goes below the fragment, and I pull the thread up, the nitinol loop up. I load two of these sutures, one green and one blue, onto this nitinol loop, and these two threads are then passed below the fragment out from the anterior inferior portal. So that's how we are holding the fragment with these two sutures. Then I take couple of millimeters above, another bite with 45 degrees, going down deep under the bony Bankard fragment, and then passing the nitinol loop. I retrieve the loop out from the anterior inferior portal, and now I'm going to shuttle other two stitches through the anterior inferior portal. So now we have first anchor which has got four threads, two going down, two above, and they are holding the fragment well, and you can actually move the fragment nicely. Now I make these threads extra so outside the cannula. So I withdraw the cannula, put the switching stick, and then pass the cannula again. So my threads are now outside the cannula. Now this is my second anchor. It is going in the inferior border like you do for a Bankart repair. Inferior most part of the bone, bony labrum lesion. I take a bite inferior to the bony Bankart, pass a nitinol loop and tie it the conventional way how you do a Bankart repair. So this is the inferior most or anchor number 2. So this is number 2 anchor. I am putting knots and I am holding the labrum down. So this is helping in me in reducing the fragment up and getting it anatomically reduced. Then I would come at the superior border and put another anchor. This is anchor number 3, which is a superior border of the bone fragment. Again, take a capsulolabral bite and shuttle one of those sutures and take a knot and then push the knot down. So this is going to reduce the fragment close to the place from where it got detached. You anatomically are able to reduce the fragment from where it is detached, and you tie knots, and this is how it is there. So 3 anchors have been placed. Now my 4th anchor involves taking 2 threads which you had passed before below the Bony Bankard fragment. I make a pilot hole, take these threads out, and using a push lock kind of anchor, it's a knotless anchor, I'm going to pull hard onto the sutures and then pass in an anchor there so that my bony fragment is actually inverted and just goes and sits right from where it is detached. And my 5th anchor again is one which where we have 2 threads which I had taken before, and I take these 2 threads out, make a pilot hole in the superior part of the face of the glenoid, and then pass it through a push lock, and I'll pull hard onto these threads and put the anchor there and then bang in the anchor there so as to reduce the bony fragment. So this is how an anatomical reduction of a bony Bankart, acute bony Bankart happens. This is something like a double row repair where you are able to reduce the fragment anatomically. See how wonderfully it is sitting back, and I am shifting my scope again to anterior superior portal just to see how well reduction is achieved. This is a follow-up of an healed acute bony Bankart lesion. And if you look into the CT scans and a 3D reconstruction, the way the fragment comes and sits and heals in an acute scenario is absolutely good. So this gives a very stable joint to the patient, and chances of recurrence becomes much less. So our idea of an acutely injured shoulder where patient is dislocated, is a young guy, has a significant bony lesion, we get a CT scan done, and if there is a bony lesion which is confirmed, we would rather do a double row kind of bony Bankart repair so as to achieve an anatomical reduction of bone to bone union so that the shoulder becomes stable. Thank you very much.
Excellent presentation, sir. It looks so simple, but I'm sure it is because of you that it looks so simple. We have one question. Do we have any questions? We can have one question. Yes, Bancha.
Yes,
really nice presentations. So you have 5 anchors in the Glenoid. Is that any problem of anchor jam? Because it's very close, especially the anchors at the Glenoid and 2 push lock.
Yeah, 2 push locks. So As I told you, Bancha, if this fragment is a bigger one, we use a double loaded. When we use a double loaded anchors, we have 4 threads, and then we have to put 2 anchors on the face of the glenoid. But if the fragment is a bit smaller, then we use a single loaded anchor, and then only a single anchor would come on the face of the glenoid after to reduce. So then the total number of anchors on the face would be 3, and 1 would be on the neck. But for a big fragment, there are 4 anchors on the face and 1 on the neck. So these are 5 anchors. But
No
yes, if
problem
the fragment is small, we would rather put 1 single loaded anchor onto the neck of the glenoid, and then take it around the fragment and then fix it with a single anchor onto the face of the glenoid. Plus there is 1 anchor below and 1 anchor above. So 3 anchors would be on the face of the glenoid. Yes.
So IPS, any problem of the jamming of the anchors?
Jamming means, threads coming.
No, overcrowding of the anchors.
Anchors.
Yeah, so you need to just, that is how you need to play with the anchors. The inferior most anchor is at the place which is at around 530 position. The superior most is at around 330 position. And you still have place in between where you can put 1 or 2 anchors. So you need to just play with the place where anchors are there. There are some people who are using soft anchors, 1 down and 1 above, and a push lock anchor in between. So you can actually do a combination of push lock and all suture anchors, put 1 above, 1 down, so that you can play with the place where the anchor position has to be.
Thank you, IPS.
Thank you,
Navid, can I ask one question?
Yeah.
Navid?
Yeah, please. Yeah, Vikram.
So I would like to ask, depending upon the size of the bony Bankart, would you do you change your technique of repair? Like if it's a very large piece, do you fix it with screws sometimes, or if you decide to do it open, do you do like that? Depending
Absolutely. I think you have to understand the limitations of your arthroscopic repair. There are cases where the fragment is big. It is essentially a glenoid fracture then. And when there is a essentially big fragment with a glenoid fracture, we tend to do with the screw fixation as well. But most of the time, you would see, and in your practice as well, around 80% to 85% times, you would have a bony fragment, which is actually accessible by arthroscopic repair. And hence I shared this technique of repairing it.
Okay.
Can I ask one question?
Yeah.
So in cases of chronic bony Bankarts, does your management differ?
Yeah, Neha, definitely the management would differ, because in chronic bony Bankarts, it's difficult to do this kind of double row repair. Then you have to actually erase quite a lot and then go down to put the first anchor. You would then go in for a conventional kind of Bankart repair, but you should have devices where you are able to actually pass in suture just below the Bankart fragment. Also, in a chronic bony Bankart, the bone becomes resorbed. It becomes smaller in size. So you don't exactly do the same way as you're doing for an acute bony Bankart. Acute bony Bankart is a fresh bone. It has got a big fragment. You can play with that fragment and bring it back. But chronic has got some kind of loss in the bone because of resorption. There is fibrosis there. So plan changes from a double row usually to a single row repair.
So do you keep a Latage ready for, do you keep in that in mind?
I think Ashish rightly pointed out when we were discussing after your presentation about patients which are high risk and patients who have got a subclinical kind of bone loss. We usually reserve Latarche for patients with adhesional bone loss rather than a bony Bankart. Bony Bankarts usually heal well, and by seeing the studies, encouraging study of Hero, we have understood that some of these bone fragments do regenerate and also become stronger as the healing would happen. And so our tendency to do a Latarche is much less in a bony Bankart rather than adhesional bone loss on the glenoid.
Okay, excellent. Thank you, IPS sir, once again.
Navid, can I ask one question?
The next talk is by Dr. Ashish Babulkar. In India, he needs no introduction. His name is synonymous with shoulder surgery. Ashish, they're all yours.
I think Dr. Satish has got some question. Meanwhile,
Yeah, Satish. Yeah.
Ashish sir, you can unmute. Yeah.
Yes. Dr. IPS?
Yeah, Satish.
Yeah. Do you have any experience of passing a suture through a bony fragment, just like Dr. Sugaya did?
Yeah, so we do have a suture passer. They I think, call it a rhino. They call it as a rhino. It's like it's something like a penetrator, but much more sharper. And yeah, we do have a rhino, but we do it usually for patients with chronic bony Bankart rather than acute bony. Acute, you can actually play with the bony fragment. If you have lifted it up, it just floats. You can lift it up and then pass it under it. In chronic bony Bankart, there is a lot of fibrosis there, and sometimes you need a device where you can penetrate and just either at fragment or just below the fragment. So there is a rhino suture passing device which is useful in chronic bony pain.
Okay.
Yes, Ashish. Thank you.
Ashish sir.
Thank you, Navid. Thank you very much. Thank you, IAS and Vidarbha Arthroscopy Society. Also, IPS, excellent case demonstration that was very elegant. Answering Bancha, I do the same technique since the last 7 years. I just use one medial anchor, which is far medial, double loaded, and I just need 2 more anchors on the anterior edge. So perhaps IPS 3 anchors, if they are positioned correctly, might be reasonably okay for most of these patients. And you can augment them with all suture anchors because we can compromise on space. Let's move on to remplissage. It's a different technique that was promoted by Eugene Wolf, and it's an augment. So whenever the Hill Sacs is large, and now most of our arthroscopic procedures for instability would be an arthroscopic Bankard procedure, and a well-done Bankard is likely to work quite efficiently with a recurrence rate that is very less and acceptable. But probably less than 1/3 of our procedures need to be augmented with a remplissage. So I don't think this is a workhorse for instability surgery as such. But whenever that Hill Sacs is very large and broad, then we might want to consider a remplissage as such. In such situations, a Bankard by itself may not be adequate as such. But we need to understand how to diagnose the Hill Sacs first and how to quantify that second. So true AP X-ray is less likely to show you the quality of and the size and extent of the Hill Sacs. But even this is a case of a recurrent dislocator who's had a putty-plat surgery, another surgery, twice failed. So it's unlikely he doesn't have a Hill Sacs. But if you look at the true AP, if you look at the central X-ray, which is an axial, you still are not quite sure about the Hill Sacs. And then you do a striker notch view. So the striker notch view was not designed for the Hill Sacs, but is excellent at demarcating the Hill Sacs and quantifying. Quickly, you will realize that this is not only a Hill Sacs, but it is a hatchet Hill Sacs as such. So Yamamoto and Sekia have extensively written on the Hill Sacs apart from Eugene Wolf, who initially promoted the remplissage procedure. Eugene had studied in France undergraduate medicine, and that's why he gave him the name remplissage, which is French for filling a glass of wine. So to me, every Hill Sacs is engaging. So I don't prefer classifying a Hill Sacs as engaging or non-engaging. And size is not the only factor. You could still have a laterally positioned large Hill Sacs, which I would safely neglect and leave alone. Any Hill Sacs that is medial is probably more sinister than a lateral placed Hill Sacs. And you want to decide how much of the cartilage is also involved here. So if you look at these articles, Carr defines that a defect 5/8 of the humerus. Now, 5/8 of the humerus is almost 60% of the circumference of the humerus, and that's way too high. Sekia appropriately reported that 25% of the radius of the head of humerus would be a significant Hill Sacs, and we take that as 16 mm. And we follow Kralinger, where the length, width, and depth of the Hill Sacs is quantified. So our MRI radiologist will measure the length in all the 3 planes and give us a Hill Sacs quotient. If that was more than 25 mm, then there's a likely chance that I would be able to perform a remplissage on that patient. So this is the CT's evaluation of the length, breadth, and you would do the depth on the sagittal scans and then give us a reading. This is a cadaveric study from George et al.'s unit, Ilya Elkinson presented. They did an experimental study where they positioned their anchor in the valley of the defect and on the rim of the defect on the medial side and lateral side. And they came to a conclusion that, at least on the cadaver, it didn't matter. Every technique worked reasonably well. But the more medial you place, the more likely that you will stiffen the patient up. So try and position the anchor either in the valley or in the center, so that you're not putting the anchor far too medially. But positioning the anchor too laterally to avoid that stiffness will defeat the purpose, because it will leave a large part of the hill sacs open, uncovered. There are several techniques, and I myself use three techniques. One is the standard simple glenohumeral technique that I'll show you, because it is simple and it is my go-to technique all the time. And alternatively, sometimes I would tie the sutures subacromially, and for that, then I need to prepare the subacromial fossa before, and then I have to shift my scope. And whilst I'm tying, I do not see and visualize how well the defect is being closed as such. So those are the pros and cons of doing the subacromial technique. And then there's an elegant pulley technique where you just have to use the sutures as a pulley. And I use that sometimes just as a whim. There's no big value advantage in doing that. I have to allude to the on-track and off-track principle that was defined by Giovanni and Nitoi. And I will not dwell on it too much, because this is largely theoretical. It is done in the radiologist room. And I cannot trust the report of a radiologist saying that this is an off-track lesion or this is an on-track lesion, because that decision remains a surgeon's prerogative. So the point here, which is very vital and very important and pertinent to this talk, is that if you have a glenoid bone defect, then even a small hill sacs will become off-track. And that's why measuring the glenoid width is a very important part of instability planning. So we must take into account the glenoid bone loss while determining whether to do a remplissage or not. Now, this is a recurrent dislocator, failed Bankard. You can see extensive cartilage damage. This is a wide hill sacs. My scope is in the anterior medial portal, and I'm visualizing. If I can visualize a hill sacs from an anterior medial portal, then it's a significant hill sacs. And if I'm struggling to find it, then it is not a significant hill sacs. In this case, because this is wide and this is extensive, this was almost 28 mm, I'm going to do 2 anchors to close this hill sacs. Whereas 80% of the times, for me, a double loaded 1 single anchor technique, 4 matrix sutures are quite adequate in coverage of the hill sacs as such. So this is the same patient. We can see that this hill sacs has been fairly covered, and you can see the defect has been obliterated, and hopefully this is going to help. This is a 4.5 years follow-up on this patient. So far, so good. And there is no altered symptom or sign of instability. The hill sacs could occur in the first episode, so it is not a sign of recurrence. It, I think, correlates much better with the velocity of trauma. And you ought to establish that you understand the difference between a true hill sacs and not to miss a reverse hill sacs, which would be a sign of a posterior labrum tear and posterior instability on these patients. So this is an example of a posterior labrum tear in a MiG-29 pilot, and you can see that there's a subtle reverse hill sacs hiding just underneath the subscap with some damage to the subscap as well. So this is, of course, a small reverse hill sacs which I can leave alone, but anything more than 10-15 mm, I would need to do a reverse remplissage or do a subscap tenodesis inside this hill sacs. But we'll stick to the conventional hill sacs here, and you can see here, I have had a couple of queries from my fellows that they struggle to do a hill sacs. Let me share a tip with you that on the top right, you can see the lateral position here, which is my preferred position for instability surgery. My scope is in the anterior medial portal here, anterior lateral portal here, and this will be the Wilmington portal. But I do not use a fixed point for Wilmington. I use my needle to dictate where it is going to be. There are 2 maneuvers that are critical to exposing the hill sacs. Number 1 is you shift the head anteriorly. The assistant can do that. And at the same time, you rotate the head in external rotation, the arm in external rotation, and this will bring into vision the entire hill sacs and create a space in the posterior aspect of the shoulder joint, allowing your instruments, cannula, and your devices to come in easily. So the 2 maneuvers is you want to do a forward shift of the head across in the lateral position and then turn the arm into external rotation. And that should open out a significant amount of space in these instability patients. And that, I think, makes my life easy. I would prepare most of these patients, I would prepare and roughen them up just by doing a decortication with a rasp. Very rarely would I use a powered instrument. I'm rather loath to using a burr because this is very soft bone, but I have to establish when I have started the rasping that the bed of that hill sacs will bleed. And if that can weep in this manner, then I know that I have done a reasonably good job. If I have not achieved weeping of the floor, then I will use a power instrument. Here, what I've done is after the rasping, I've just switched off the water, and that allows the nice depiction of the decortication. So it's a very gentle decortication, allowing the bed to weep itself. And then I know that this is an adequate decortication. I follow that with the insertion of anchor, usually a single anchor, which is a double loaded anchor, 5.5. And once that is done, we have 4 mattress sutures and we sequentially pass them always from lateral to medial. And you keep about a couple of centimeters between them so they don't bring them too much closer. Take more of the tendon. If you start taking bites through the muscle, then that means you're going to over tighten this too much and then you'll compromise your Bankart repair. I, for one, am a little unorthodox. I finish off my Rempli, tie all my sutures, and then proceed to doing a Bankart. I don't like too many sutures inside the joint, but most surgeons would advocate that you insert the anchor, pass the sutures, but don't tie them, come back later and tie them. So I'm rather lazy and I like to finish off the posterior job and come in. I have never done an alternative technique. If you do it in a proper manner and you don't over tighten your posterior repair, I don't think it compromises your anterior bites at all. So after having taken sequential bites, this is probably the only surgery that I would do with an arthropierce or a bird beak. Most others I use an indirect suture shuttle, but this is the only technique I would use a bird beak and to sequentially pass the sutures again from lateral to medial and then tie them again from lateral to medial as such. And this is what I achieve in the same patient. You use a watertight complete closure. I evaluate that. So none of the defect is open, which means that we've positioned the anchor well, we've taken the bites appropriately, and then I proceed through the same viewing portal for the Bankart repair. I think this is probably the most important take home on this slide, and it's very critical. When I use the posterior viewing portal for passing my bird beaks to take the bites from the posterior tissues, I will use a much more superior bite and I will not use the same viewing portal because subsequent to tying the sutures, if I use the same portal to pass my cannula in, I can disrupt my Rempli. And that's why I wanted you to dwell on this more, that I have to come back exactly in the same point that I have prepared the posterior viewing portal. All my bites are much more higher than the posterior viewing portal, lest you disrupt your repair because I have tied all my sutures as such. So this is very critical. The junior surgeons need to spend a little time to ensure that they're not messing both things up. So be careful with this technique. A couple of tips here. My viewing portal is a little more superior, so you can visualize the hill sacs appropriately. I always do the Rempli, complete the tying, and then do the Bankart later. But to each his own, you can use any alternative technique that suits you. Anchors not to medial, pass the sutures to the tendon, not to the muscle, and then reconfirm that the hill sacs has been disengaged. Another quick pearl, I would want everyone to wake up just for this 1 second. If you have a combination of a Bankart, posterior labrum tear, and a hill sacs, I would first do the posterior labrum repair, then do the hill sacs, and then finish the Bankart. Because if I do a Rempli and repair that, and then bring my Wilmington portal in for the posterior labrum tear, I would disrupt. And it's possible that in the hubris, you see the hill sacs, you do a Rempli and forget to do a posterior labrum tear. So it's very important that you change the sequence of repairs in these patients. So to each his own, you have different techniques of doing the Rempli. The question is, if you have a wedge-shaped Rempli, so just at the end of my presentation, this is probably not amenable to your conventional Rempli technique if you have a wedge-shaped hill sacs. And such cases, rarely I would use an osteochondral bone graft or sometimes rarely an iliac crest bone graft when I'm unprepared or the allograft is not available. So this is a epileptic, and you can see I have put in a screw here to fix a humeral head allograft into the defect appropriately, and and then we finished the remplissage and the anterior and posterior labrum repair in this gentleman as such. So such hill sacs which are very deep would require. In the US, they have prostheses which are used to fix larger defects. We don't have the uh, availability of these hemicaps, but the long-term results of these hemicaps are not available. So I'm also a little skeptical in using them. This is another example. This is the failed Bankard. You can see he's a very big damaged hill sacs, which is going from anterior to posterior. Because this was done in Surat, we chose to do an iliac crest graft because the allograft is not available there. And so we fixed this in with the screw and ideally, and then done the revision Bankart repair in a robust manner. So this can be a tedious, long drawn procedure. So you have to allocate that much time to this patient. Just a quick note, which I might cover in the arthrolatagie, that whenever I've done a latagie, I've never ever done a remplissage. Actually, just a couple of exceptions, but I'll deal with those when I do the latagie talk. So by and large, when you extend the radius of curvature of the latagie, the hill sacs becomes redundant, so it becomes non-engaging. So it doesn't add another complex procedure to your already complex procedure. So in conclusion, what have we learned today? What percentage of Bankart should be remplissaged? Less than 1/3. What extent of defect qualifies? I think a medial defect qualifies. And size would be more than 16 mm medial lateral, not anterior posterior. If you do it correctly, the remplissage will not lead to stiffness. The location of the hill sacs is much more important, whether it is medial rather than lateral. And deep hill sacs is not such a worry, but a wide medial hill sacs is much more of a worry. So hill sacs may not be innocent. You would need to do it in certain number of patients who are more likely to dislocate or at risk for redislocation. Most of the times I use one double loaded 5.5 anchor. The post-op care remains the same, and consistently literature has proven that a remplissage will most often heal very nicely, even on MRI studies as such. Thank you for your attention.
Thank you, sir. Thank you, Ashish, sir. Any questions for Dr. Ashish?
Sir had answered it right in conclusion very well. You have answered all the questions in conclusion.
Right.
I hope so. Thank you.
Sir, I have a question. In that patient which you showed where you did an osteochondral allograft, you had used metallic anchors on the glenoid as well.
Yes, Navid, that's a case that was done in 2007. We didn't have biological anchors then. We've all switched to complete bio anchors now. But that was an epileptic from Hyderabad, and 2007, we were hard pressed to get all these bio anchors. So we were using metal anchors at that time.
Right, sir. Okay. Thank you, sir. Thanks a lot. We move to the next talk. It's by Dr. Robert Hajler again on management of posterior labral injury. Robert?
Okay, let me get going here.
Yeah.
Okay. Is the screen shared now?
Yeah, it is, yes.
Yes, Robert.
Okay, very good.
You're good.
Okay, same disclosures. I'm going to mention the podcast a couple of times in this talk. I think we've got some really nice posterior instability podcasts. Starting off with a case, this was a 16-year-old high school football player, American football. He actually originally injured the shoulder weightlifting and felt it slip and pop, and he had that sensation many times subsequently. Physical exam significant for positive jerk test. You can see as we look at the MRI scan here in that middle parasagittal view and on the axillaries as the axials as we go down, the large posterior labral tear probably initially was a posterior bony Bankart. Be able to see that a little bit better on the 3D CT scan there, and then also on the 2D CT scan. So for this posterior instability case, recommendation was for arthroscopic posterior Bankart repair, and he's done subsequently very well with that. So those are the kinds of patients that we're going to be discussing, and we'll try to go through a little bit of natural history, the clinical presentation of these patients, a little bit on bone loss, some techniques, and the results of arthroscopic repair of these patients. This was a podcast that I did. Study out of Mayo Clinic was discussed, where they did a very nice epidemiological study in Rochester, Minnesota, the county where the Mayo Clinic is located. They can keep very good track of records, and I think this is probably our best information, and similar to Hovelius's study on posterior instability. Posterior instability was uncommon amongst instability patients, and if you look at the survivorship free of surgery at 10-year follow-up, over 70% of these patients ultimately went on to have surgery for this problem. It may be that non-operative treatment for posterior instability is not as good as we've thought in the past. Posterior instability patients often present with vague symptoms, pain or weakness only, symptoms like popping, catching, loss of function, and sometimes they won't really report to you that they had an initial injury or posterior instability event. Another interesting podcast episode, and these are free on the Arthroscopy Journal's website and on all the podcasting sites, that we did with Dr. Provencher, study from last year, but the podcast was a recently released one where he discussed their findings doing research on bone loss and posterior instability. Unlike the case actually that I presented, which looked more like anterior instability bone loss, posterior bone loss seems to be a bit more attritional, and you have these chronic wear problems, and they don't tend to be those kind of flat defects like we see in anterior instability. We're a lot less clear on the indications for treating posterior bone loss than anterior. On techniques, I just put in a plug for Dr. Burkhart's books, particularly his first book where we have the basics, his philosophy of doing arthroscopic shoulder surgery. For me, for doing instability cases, it's important to do these, particularly for posterior instability and lateral decubitus. And the way that we set up the operating room, we have the surgeon and the first assistant on the affected side. And across the table, there's a second assistant that you can see in the foreground of the picture there who's doing manipulation of the arm, a large bump under the axilla like that. And pushing downwards, it can be really helpful for distracting the humeral head away from the glenoid and getting good working space there. And if that assistant is skilled, they can really improve your view and ability to access the joint and instability surgery. So that's how I approach these cases. Something that always surprised Dr. Burkhart's visitors is how high he ran the arthroscopy pump. Minimum 60 millimeters of mercury. So for a lot of people, that's surprisingly high. I don't usually run it quite that high, but I'll go there if needed to be able to see. I'm going to show a few cases from our most recent textbook. This is a right shoulder. You can see that the labrum prep and bone bed prep has already been done. We're going to use a suture shuttling device here. This is going to be a 2-anchor repair. We retrieve that shuttling wire out of an anterior portal, and you don't have to always make an anterior portal in posterior instability surgery, but I find myself doing that quite often, probably most of the cases, in order to access the bone for prep and for suture passing. These are Arthrex percutaneous insertion cannulas where a nitinol wire goes through a needle, and then there's a dilator and the guy goes over that. That's really helpful. As you can see, there's 2 portals there working posteriorly for making those kind of accessory portals that are key for proper angle of approach for anglement. So here we're bringing that tape suture out through the posterolateral portal, and we've already made the drill hole for that. So we'll just load those sutures into the anchor, and then that anchor will be able to slide percutaneously down through that small incision. With curved guides, we may be able to go a little bit away from these percutaneous incisions and accessory portals, but typically my standard posterior portal does not have a good angle of approach for anchor placement, and so I'm almost universally making a percutaneous posterolateral portal or 7 o'clock portal like that. So we'll retrieve those sutures out, cut those, and then the same sequence for the more superior anchor, using a suture shuttling device coming in through the posterior portal, retrieving that out, anterior, bringing a tape suture through the capsular labral tissue, and then you can see again that same angle of approach is suitable for this higher anchor. You can see how there's been just a little bit of articular cartilage removed in order to bring that tissue up slightly onto the face of the glenoid. So that's a very nice technique for doing a knotless construct with a tape suture and push-in type of anchor. This is another case showing knotless anchor, a different type of knotless anchor, these newer self-cinching anchors. This is a left shoulder, same size of lesion and location as you saw in the last case. Here I'm working across the joint from the anterior portal, just prepping that tissue there, mobilizing the capsulolabral tissue. Will again create just a little bit, 1 to 2 millimeters of articular cartilage removed so that we have a shelf for anchor placement. There you see my angle of approach coming in, and I'll show that externally later, but through that percutaneous posterolateral portal. And then this is a retrograde technique coming in, shuttling the working suture through the capsulolabral tissue. And then in this type of anchor, that working suture gets shuttled back into the anchor body, and there's a self-cinching type of mechanism which secures that. What's nice about this type of anchor is that you can pull that suture somewhat tight, but not fully tight, and leave yourself some tissue mobility there for passing the suture for the next anchor. And then once I have both of those placed, then we can sequentially tighten each suture and get a really nice low profile and secure repair there. Both of those patients, non-contact athletes, so I think that it's okay for that type of single point of fixation per anchor. In this case, this was American football player, a little bit of a larger lesion, and he's going to return to contact sports, so decided to use a more traditional type of knotted suture anchor where we get 2 points of fixation per anchor. Here's that technique. In the Thrax shoulder system, you can get those little ring curettes, which are very nice for preparing that posterior glenoid. Here we see again coming through a percutaneous posterolateral portal. Here's an anterograde suture passing technique with a labral scorpion device. Suture shuttling technique. So there's all kinds of different ways to shuttle those sutures through. But you'll see in our final construct, we're going to tie these knots, and we'll get that nice restoration of that bumper effect and decreasing that capsular volume. You'll see that our 2 points of fixation per anchor, and I think a very nice result for that contact athlete. Often close the posterior portal. I'm going to show that in another video here. So this is actually the original case that I presented in this talk. You can see the angle of approach there, the spinal needle there. Oh, let's go back up. So you can see the angle of approach there. the 7 o'clock or posterolateral portal, and this blue arrow here on the external view shows approximately where that is. There's this anchor is actually going through a Port of Wilmington portal, the one that's shown there, but you can see on the external view in blue where the typical location of that posterolateral portal is. And even though those are coming through the capsule close to one another, the angle is different enough that it gives you that nice, more perpendicular approach to the glenoid instead of coming at an angle where you might skive across the face. So in this system here, I'm not using the percutaneous nitinol technique for coming through. I'm just following the angle of my spinal needle with this drill guide. But you can see what you can see once we get that through, how we'll get that nice angle of approach very low down posteriorly for this left shoulder. And then this is demonstrating an all suture anchor. This is going to be a 2.3 millimeter drill hole, but we'll get to, this is, as I mentioned in the case presentation, this is a contact athlete also. So went with a knotted technique where we get 2 points of fixation per anchor there. But I think this is a nice and good bone for a young person. An all suture anchor gives you really nice fixation and decreases the size of the drill hole for placing this anchor. So this is our final result from that young 16-year-old football player. 3 points of fixation, double loaded, and we'll come in and just show that secure repair. And then in the next slide, I'll just show, I think that in a lot of these patients, it's really helpful to close your posterior portal. So we just come through with a retrograde suture passing device, one pass. The cannula for this is just right outside of the capsular tissue, and we can just retrieve that suture. And then this is tying, you have to tie this blindly, but you tie it through the cannula with the cannula just outside of the capsule there. And that's a good way with either with a number 2 non-absorbable suture or with a PDS like that. A very nice posterior capsular closure. Jim Bradley's work on posterior instability has been the foundation of our knowledge for this, and this meta-analysis from 2014, 27 studies using arthroscopic techniques, over 800 shoulders. We can see that with these types of techniques, we get very low rate of recurrent instability and good outcomes with high patient satisfaction and a high rate of return to sport for these kinds of patients. Another systematic review recently with over 800 shoulders, you see very high levels of return to sport and good recurrence rates at short-term follow-up. Another interesting study this year, Dr. Bradley looked at his experience with which patients went on to revision arthroscopic posterior shoulder instability surgery. And not surprisingly, glenoid bone loss was associated with that. And you can see that even these small amounts of glenoid bone loss really make a big impact in these patients. And labral width was inversely associated with the need for recurrent instability as well. Still a very low rate of revision surgery for these patients, but patients who went on to revision had worse outcomes and a worse ability to return to sport and satisfaction rate with surgery. So I think posterior instability is very satisfying to treat for shoulder surgeons, has very good rates of successful surgery. And I think the techniques for that are straightforward. And so thanks again for having me.
Thanks,
We'll
Robert.
turn it back over.
Yeah, thanks. Excellent talk. Yeah. Any questions?
I hope in doing posterior labral, we only take labral bite, and we should be very careful that we should not take the capsule and tight the capsule when we are doing posterior labral repair. Any tips and tricks on how to avoid that over tightening of posterior capsule while you are dealing with the posterior labral injury? Unlike what we do in the anterior instability, we over tight the capsule as well.
Yeah, I think it depends a little bit on the patient. I mean, that the patient that I showed with a little bit of bone loss, and he's a young kid who's a contact athlete. I took a little bit of capsular bites in that patient just to make sure that I did the best job of preventing recurrent instability, because he had real posterior instability. I think your point is well stated for patients who have more of pain and those kind of vague symptoms of not being able to perform, where it's more of a pain relieving operation. But some of these patients really do have true instability in that direction.
Okay.
Okay. As of now, there are no questions, Robert. So we just wait. And we go to the next talk by Mukesh. Mukesh is the secretary of Arthroscopy Society Nagpur. He's a very versatile surgeon. And Mukesh is going to talk on management of chronic locked unreduced posterior dislocation. Yes, Mukesh.
Thanks, Navid. Am I audible? Yeah. So
Yeah.
now, after all the arthroscopic surgery and common pathologies, I'll speak on something which is quite uncommon, and open surgery in the shoulder. First of all, posterior shoulder dislocation or posterior labral injury itself is very rare, and in that, locked posterior shoulder dislocation itself is again rare. It was rare in 1952, rare in 1982, and still I think it's rare. But the whole thing which Dr. McLaughlin has mentioned, it's often missed because of diagnostic trap of rare occurrence and possible negligence by the unwary surgeons. So the etiology, most common etiology is trauma. But one thing we should come into your mind is seizures and electric shock. So patients who have a history of seizure or electric shock, you should have a suspicion if they come with shoulder pain and stiffness to you. It's often missed because seizures are given more important. Management of seizures or polytrauma patient is given importance. So once you know the history of patient, whether they have seizure or epilepsy or electric shock, then the classical physical examination for chronic locked posterior dislocation is locked external rotation. So patient will have reasonable good forward elevation or abduction, but once you check their external rotation, it's usually locked by the side of the chest, as well as when you abduct and try to do external rotation. So these two, one, the strong suspicion from history and a classical clinical finding should raise the suspicion that you are dealing with a chronic locked posterior dislocation. So a routine true AP X-ray may show you light bulb sign, but there are very high chance that you may miss the posterior dislocation if you do only true AP X-rays. So with this history and positive clinical findings, always go for axillary lateral, or if it's painful, go and get a scapular Y view, because then you are not going to miss this posterior dislocation. As in this X-ray, you can see it's a classical locked posterior dislocation with a huge reverse hill sacs. Then if you are planning for surgery, a CT scan is a must, because that helps you to quantify the amount of humeral bone loss, as well as to know the amount of glenoid loss or any arthritic changes. As you see in this X-rays, various CT scan, the one in the right is a very chronic dislocation with a sclerotic margin. The one with a dislocation and lesser tuberosity fracture. The last one, it's like ossification of Polpsa lesion, and the one which the CT shows is a significant humeral bone loss. And then MRI is also necessary to assess the integrity of the rotator cuff as well as labral injury, so that you can prognosticate your surgical results to the patient. So once there should be high suspicion from the history, clinical examination, and CT scan and X-ray to plan your treatment. So when you decide you need to go for management depends upon the age of the patient, the activity level of the patient, the side involved, the duration of the symptoms, the amount of bone loss, and of course the arthritis involved. So if it's an elderly patient with non-dominant side involved and it's a very chronic, say 8 to 10 months of duration, they have done some modification activity and they have minimal pain, then it's often conservative or willful neglect if the patient is not that demanding. But if it's a young patient with dominant or non-dominant and involvement, pain is significant, and then you need to decide the clinical surgical management of the same patient. So this is a small surgical chart. The decision making mainly depends on the amount of cartilage damage on the humeral head. So if it's less than 25%, you can try for open or closed reduction, and if it's stable, nothing to do. If it's unstable, then you can do simple subscapularis transfer. If it is 25 to 50%, then you can use subscap with or without lesser tuberosity, like modified McLaughlins. You can use allo or autograft reconstruction, or you can do proximal humeral rotational osteotomy. If it's more than 50%, arthroplasty is the option, but again, it depends upon the age of the patient. If younger the patient, you can use allo and autograft to reconstruct and save the humeral head. This lady, she's a 35-year-old lady, had an electric shock while she was doing some of her farm activity and was, as usual, diagnosed with a stiff and painful shoulder and was referred to physiotherapy. Since last 3 to 4 months, she didn't recover, and then she came to me. The X-ray showed there is some problem with the humeral head, and CT scan confirmed that that is a locked posterior dislocation. And you can see the classical sign of locked external rotation. I usually prefer to do modified McLaughlin's procedure in younger patients. So a routine semi-beach chair position, deltopectoral approach. Identify the biceps tendon first, because then it helps you to identify the anterior and posterior side of the humeral head, because here the head is dislocated. Once you do that, identify the lesser trochanter tuberosity and osteotomize lesser tuberosity with the proximal 2/3 fibers of subscapularis, and you try to fill that defect into the reverse Hill-Sachs lesion this way. You use 2 anchors, 2 or 3 suture anchors. If the bone is big enough, you can use your metallic screw and then take a bite through the subscapularis and reattach that bony part to the defect in the humeral head. And most of the times I do biceps stenodesis as well, because in long standing, there are some biceps atresion or biceps lesion also. And always check the stability on table. As you see here, posterior push and internal rotation also, the joint is quite stable in spite of dislocated since 3 to 4 months. Another case, he met with a road traffic accident, a 35, 40-year-old gentleman, but had a chest injury also. And so in managing the chest injury, the shoulder was neglected, but the initial X-ray was not that normal, but had missed. You can see there is an overlapping of the humeral head over the glenoid. And subsequently, he came with the locked posterior dislocation with lesser tuberosity fracture. And you can see it's a significant reverse Hill-Sachs with a non-union of lesser trochanter. Again, went in and did his modified McLaughlin's procedure. And as you see, after fixing it with 2 metal anchors, this is his follow-up X-ray, which shows sometimes there is bone resorption. But I think, again, the subscapularis tendon is intact in that place. So it prevents further dislocation of the shoulder. As you see, this patient at the end of 6 to 7 months with full range of movement, painless and quite stable shoulder, able to do all activities with that shoulder. This was a quite delayed presentation, presented to me almost 8 to 9 months after he had an epileptic seizure. Again, was missed because of obvious reasons. And when I did his MRI and CT scan, there was some changes on the glenoid, as well as there was a significant reverse Hill-Sachs lesion. There was ossification on the posterior inferior glenoid, ossification of the posterior inferior capsule along with the posterior ligament over there. So always, as I told you, identify the biceps tendon. And most importantly, you should know how to relocate that locked humeral head. Never external rotate. As soon as you do biceps stenotomy, you will fracture the humeral head, because their humeral head is very soft because of long-standing chronic dislocation. The thing which you should do here is you should give a posterior push, do the internal rotation, posterior push, disengage the lock humeral head from the posterior glenoid by giving a little lateral traction, and then do external rotation and reduce it. And then again do your modified McLaughlin's procedure, fix it with 2 anchors. As you saw here, how good the lesser tuberosity and the sphericity of the humeral head is maintained, and patient recovering well after his post-op rehab program. You need to really educate your patient that the rehab takes little longer time and they may have some loss of external rotation if they don't do proper rehab. This was another case which had a significant glenoid humeral bone loss, as you see, and it presented to me another 4 to 5 months. That was a significant proximal humeral bone loss, roughly around 40 to 50%, but he was very young. So I tried to fix it again with modified McLaughlin's, but it was getting dislocated again on table. As you can see in that video, it's getting dislocated. So it was very difficult to relocate it back. So I have to remove that screws, relocate it back. And as I was well aware from my pre-op CT scan, I have mobilized the patient and told him that if it dislocates or it's unstable on table, I may go and do a hemi-shoulder replacement in your case. So the indication of doing hemi-shoulder or total shoulder replacement in lock posterior dislocation is if it's more than 50% humeral head involved, or if the duration of lock dislocation is more than 6 months, because then the humeral head becomes non-viable or the cartilage becomes non-viable. Age is a relative indication, but because it depends more on the amount of humeral bone loss, but it gives excellent pain relief, good external rotation, and very low recurrence rate. Whether to do hemi or total shoulder, if the glenoid is significantly worn out, then you can even do a total shoulder, because that has also given good results in the literature. So that's the post-op X-ray of the patient, and that's the activity level of the patient at the end of 6 months, able to do all activities, no recurrence, no instability, full movements. To complete the algorithm, personally, I don't have any experience with auto allograft, but this seems to work well in younger patients with more than even 50% humeral bone loss. The literature even says in case of seizures, if you have a bilateral lock dislocation, you can use the humeral head of one side and reconstruct the other shoulder and replace the other one, or you can use an allo or autograft, whichever is available, and give good results. Rotational osteotomy is a good option in young patients, but patients should be very well prepared for rehab program because you are rotating the proximal humerus. This also works well, but all this have a very small, we don't have bigger series because of rare occurrence. Complications, they have chronic shoulder pain, recurrent instability, allograft resorption, AVN, non-union, and post-op stiffness as well. So take home, it's a very rare occurrence. You need to have a high degree of suspicion from the history, lock external rotation on physical examination, X-ray, CT scan is a must, and lateral view or Y view is a must. You need to tailor-made the management depending on the patient's age, activity level, and of course, amount of humeral bone loss. Thank you.
Thanks, Mukesh. Excellent talk. Do we have any questions for Mukesh?
Mukesh?
Yes, sir.
My preference is always to do the modified McLaughlin as possible, but we've in the third case where you were compelled to do a hemi, so
Yeah.
we've used a humeral allograft. Autograft means iliac crest is not appropriate because here we are doing cartilage, so the reversal sacs is facing the glenoid. So we prefer a allograft from the humeral head, or even a femoral head allograft works well in our hands. But without prolonging this discussion, we've written a paper on the management of neglected posterior dislocation. I consider one of the better written papers by us was that on JAJS. So have a look at that, because we've defined a critical fragment, which is the area between the hill sacs and the biceps. Okay. So we can identify, in that case, the critical fragment was type 3. So there was very little fragment for allowing a modified McLaughlin.
Agreed.
As such.
But
Yeah.
availability of allograft.
Yes, sir. That's what we were going to ask. How do you procure the allograft?
Yeah.
So at our hospital, all our replacements, even hip, knee, and shoulder, the graft, we have a fresh frozen graft availability. We do subsequent tests on them. It is maintained by a doctor and a nurse together. So both have to approve the quality of the graft. They're tested over 6 months and then made available. So we have that. Tata also has that facility. And it's much preferable in younger population if you can do that and avoid the hemi on those.
Agreed, sir. Totally.
Right, sir. Thank you.
Yeah.
Thank you. Yes, sir. Last talk of the evening, glamorous arthroletargy. All yours, sir.
Thank you, Naveen. I will try not to prolong the agony. I have reduced some of the videos and I'll rush through this presentation so that we can finish reasonably timed. Once you have a glenoid bone loss, there are several options. Letargy is not the only option. You have Ilectris bone graft. Marcus Scheibel has a large body of work on that from Berlin. I have seldom done a Bankart and Rempli in the person who's not a contact athlete, is a female, is less likely to dislocate. So even 15-18% bone loss I have treated with the Bankard Rempli. And of course, you have the arthroletargy as such. So to each his own, but we must understand that all the letargies that we collectively do between us, each of us are not the same. So some of us use congruent arc, some of us use anatomical letargy like Gilles Walsh, some of us cut the subscap completely, some of us split it, some of us keep the graft standing, sleeping, congruent arc, and then we also have variations on how we close the capsule. So not all of us have the same technique. So we're probably not talking about the same technique in all of us. The debate between open and arthroscopic will continue. We had a large series of open letargies. In fact, when I visited Jodhpur and came back in 2005, we introduced the letargies open to India, and I was a big proponent of open letargy. You will be surprised to know that I was agnostic towards arthroscopic letargy at that time because our open letargy was doing well. And every surgeon I visited abroad told me never to do an arthroscopic letargy because it's a dangerous procedure. Some quirk of fate, I visited Laurent Lafosse, and then in one day, he did 5 arthroscopic letargies on the trot back to back. And that changed my mind because he made it look so simple that I realized that there is an option to do it reasonably well. So there is a steep learning curve, and it is not mandatory that all of us perform an arthroscopic letargy, but I'll share an anecdote at the end with you. The risks of bleeding, nerve damage is significant if you don't know your anatomy, if you've not been extra-articular through the spaces, because it is largely a soft tissue endoscopy rather than an arthroscopy. The critics have always commented about the arthroscopy letargy not closing the capsule, not repairing the labrum, not addressing IGHL, and hopefully I'll be able to cover that as well. But we must understand that irrespective of whichever letargy we do, we need to do it in a precise manner. It's a very complex surgery. Even an open letargy in my hands is stressful because the complication rate is far, far higher than an arthroscopic Bankart. A failed Bankart has always a recourse that I would also do a revised Bankart again on that patient, or I still have an option of a letargy, but revising a letargy can be a nightmare. There are 10 different steps, I would say 10 different hurdles, 10 different learning curves on the arthroletargy, and you need to break it down. But you need the whole instrumentation set, like this alpha beta guide to position on the coracoid, like the issue here where you're seeing that the graft is absolutely flush to the glenoid, and the placement of the screws is still a challenge. Even in the master's hand, 14 to 16% of his screws are suboptimal and not completely placed. It is absolutely mandatory to uncover the axillary nerve. This is what we're seeing here. It is right there on the medial side of the subscap. So before we do the subscap split, we identify the medial side, we identify the axillary nerve, and only then do we start the split. I will tell you, any of us who uses the medial suicide portal, any of us who uses the arthroscopic letargy or arthroscopic bone Bankart fixation, all our drills will pass right near the axial nerve, kissing the axial nerve. So it is mandatory. We understand the path of the axial nerve, define that, and then move ahead, and then proceed to doing the subscap split. Now, the challenge here again is to identify the upper 2/3 and lower 1/3 and start on the tendinous side. So this is the left shoulder that you're seeing. I'm starting from the lateral to the medial side, because you start on the muscle side, it gets very fleshy, and there's a lot of fraying, and that can disrupt. And you want to protect the cartilage underneath also. So a lot of maneuvering of the shoulder, positioning, internal rotation, pushback maneuver to allow and save the cartilage. And an ideal split is very important. Positional split is very important. Along with the axial nerve, it's also very, very necessary. We are to isolate the musculocutaneous nerve here, medial to the coracoid as such, and then proceed to complete the subscap split here that you see, and then come in with your guide. So this is a plastic cannula that is protecting the axial nerve when the drill comes in, and you're monitoring the graft and ensuring that the graft doesn't shift, it remains flush, and you're not too proud on the graft, you're not too medial on the graft, and of course not too inferior or superior as well. So the three-dimensional orientation of graft positioning, it takes a much longer time, and we made a lot of errors in our initial practice, and I'm going to share all that with you as such. So over the last 2 years, I knew that the lacunae was the lack of repairing the labrum. When a labrum is available, we finish the Latarjet by performing the Bankart repair on that, because I have great faith in the labrum for the reason that I think it brings in a lot of proprioception. So if there is a labrum and we can repair it, then I would go ahead and finish and do this. It might appear as an overkill, but some of us are very keen repairers of the labrum along with the Latarjet. Laurent Lafosse doesn't agree with that because he believes the capsule will reform. And sometimes it is better to leave a complex procedure as simple as you can and not make it more complicated. But if it is possible, then we just put in one anchor there and use the labrum, pull it up taut because you want to put it, repair it in a tight manner, and then finish off the procedure. It will take another 15 minutes extra towards your Latarjet, but it's a value addition, I think, because you can have a Latarjet that is not dislocated but still feels unstable or unable to throw the ball. Alternatively, when we are doing a revision Latarjet, then we use the same technique to use an Edinhibinate and you do all the steps except the coracoid. But there's a challenge here because I put in the guide and the screws before I remove the iliac crest graft here. So it's important to understand that your drilling of the wires and the screws must happen before, and then you pick out the graft. I measure a 25 by 10 mm grasp, and then we flatten that off with a burr, and then go ahead and do a similar arthro-Latarjet. But there are challenges because your conjoint is intact, your coracoid is intact, so you don't have the same luxury of space in these patients. Mandatory to do true AP and axial X-rays to evaluate your screws, your positioning of the graft, location of the graft is very critical. And I must also say that there's a change in the narrative with Pascal Boileau introducing his endo button technique, which is still not yet available in India. At some point it will be, and it has its pluses and minuses. The graft positioning is far better with the endo button, but the compressional graft that you achieve with the screw may be a little suboptimal. And of course, every technique which is new will bring in its learning curve, and we'll take a few cases to learn. The learning curve for both these techniques is pretty high. Whatever you do, whether you do an open or arthroscopic, it is absolutely desirable to do a repeat CT scan. We do that between 3 and 6 months to confirm graft integration. There is absolutely no guarantee that the graft will integrate. So one has to be very perspicacious on that front. The other study is very important from Moroder in JSCS 2014, that if you were to do a Latarjet without bone loss, I think he's from Gilles Walsh unit, and they had a 22.2% failure, and they had an extensive graft osteolysis in their series, which was just unacceptable. Because doing Latarjet, there were questions about Latarjet in the fresh bony Bankard or the first time dislocator. The graft will dissolve because according to Wolff's law, if it is not needed, entire graft will lose its capacity and the screws will remain floating there, creating damage as such. The arthrolatage in the expert hands, these are all top-notch surgeons who do arthrolatage on a routine basis. The complication rates were very less, much lesser than the open letarge as such, but I don't think this can be extrapolated to all the orthopedic population as such. This was our study which has been submitted, and we did a serial comparison between our first 25 and next 25 to check the learning curve and graft positioning. We got it right. In 80% of times, our graft was on the appropriate lower segment of the glenoid, but in 10% we got 20% we had grafts in the middle segment. In the axial plane, our grafts were recessed in 1, so that was medialized, and were proud in 2. They're flush in 22 of the patients, and average medialization of 2.45, lateralization 3.33 is still acceptable. Up to 5 mm lateralization, I would still accept that. The one important feature of our study was if your graft is inadvertently fixed high, if your subscap split is high, then that means the patient will lose their external rotation. And although the p-value was not significant because they were not big numbers in our study, one must be careful. This was a comparison between the first half of our patient and second half, and you can see we had more parallel screws in the second half. We had much lesser screws that were out in the second half, and we had no screws which were screwed in the second half. So we kept getting better as we start doing more and more of these surgeries. Again, as I reiterate, do not take the open letarge casually. This is a study from JP Warner's unit, 30% complication rate. And during neuro monitoring, that study got a NEERS award. There was 76% neuro abnormalities because you tend not to see the nerve in the open letarge, and it's probably not necessary. But because of your dissection and the heat and the cautery, it's very important you take care of the nerves as well. Amongst our series, we had 3 patients who needed a screw removal. Now it's about almost 7 out of 100 patients that needed screw removal. We had 3 osteolysis patients, 2 infections which were only superficial, 1 brachial plexopathy which was transient and then recovered after 3 months. And we had 1 stiff shoulder 4 months post-op. And 2 patients redislocated because they ruptured the graft. That happened because they stopped their medication in the immediate aftermath of the surgery, within 2 weeks of surgery, and we had to do a revision letarge on those. In conclusion, it's important to understand that the soft tissue repair in the presence of bone loss is a suspect technique. You do need a correct technique for bone reconstruction, whichever technique you choose, whether it's the Gilles-Walsh technique or the congruent arc technique or the arthroletarge. Failure and OA are the 2 main bugbears of the letarge, but certainly I wouldn't use the letarge as a stick to beat every difficult dislocation, although he's complex and contact athlete. In the absence of a bone loss, even in a contact athlete, I would still prefer the anatomical Bankard and a Rempli as such. Thank you very much for your attention.
Thanks a lot, sir. Any questions regarding the arthroletarge? Yeah, Neha, yeah. You can unmute yourself.
Neha, please unmute yourself.
You said that arthroletarge has a steep learning curve. How much steep it is?
Right. It depends on your individual skills. Between our first 25 and the second 25, we had a big difference, but it is considered. There's another similar paper from France where Jean has looked into this, and he said 50 to 75 arthroletarges, but that should be closely compacted 50 to 75 arthroletarges. Our first 7 arthroletarges were on cadavers, and then our first 15 letarges were arthroscopic evaluation, coracoid preparation, and then open. And then we slowly went in, and we went in as a skeptic because as I said, I started as agnostic. I was against the arthroletarge. And slowly we mastered that. It allowed us to understand the anterior anatomy. So our arthroscopic AC joint fixation got improved. And so we shifted to that. And that was the biggest benefit of the arthroletarge that we had.
Just for the sake of this question to Dr. Neha, is that the learning the arthroletarge is extremely steep. Is a steep means it is very, very steep curve. And if you read the classic articles by some of the Italian guys also there, the first 25 ortholetarges are your struggling period. Okay, unless you do at least 25, you will be struggling. And if you read the classic book by Gary Gartzman, he told that you don't go with the ortholetargy of a single go. You just go on, as Assis is referring to, you go something diagnostic, then you just see the coracoid, see some release, try to see the nerve and whatever, because it is a step ladder pattern. Otherwise, in single go, even if you do 7, 10 cadaveric dissection ortholetargy, you can't go in a full blown, because I'm also doing the ortholetargy, but it is a very, very steep learning curve.
Right, sir. We have a question for Mukesh from Dr. Anup. Is there any role for reverse remplissage in such cases?
Provided the lesion is too small, and if it's a less than 25%, you can even do a simple subscap tenotomy and attach it over there. Not ideal like remplissage where you just tenodis without detaching it, but here I think you need to detach subscap and reattach it to the defect.
Right. So any more questions from anybody? Okay. So I would like to hand it over to Dr. Satyajit, our president of Arthroscopy Society Nagpur, to thank everyone and just wrap it up. Satyajit, sir.
Yeah. On behalf of the Arthroscopy Society Nagpur, I'm very much grateful to Rob and Ashish for their very nice and elaborate talk. Dr. Bansha,
And
of course.
Bansha also.
Yeah, Dr. Bansha, he's India's favorite. He had very nice, I heard India talk. It is probably one of the best talk I have recently heard. And I am also grateful to Dr. Samantha, Dr. IPS, who had to leave a little bit early for some prior commitment, for giving us a chance to interact with international stalwarts. And of course, our local stalwarts, Mukesh, Neha, and panelist Satish, Amit, and Vikram. Thank you very much. And I hand over now to the IAS coordinators. Are they there, Pradeep or Sandeep?
Yes, Sandeep
Yeah,
is
yeah, yeah, yeah. We are here, sir.
Yeah, Sandeep, thank you very much.
Thank you.
The workhorse of IAS. Thank you. Please wrap up for all
Yeah.
of us. Thank you.
Yes, thank you. Thank you very much, sir. So, dear friends, we have another interesting webinar coming up. That's a 56th webinar. It's a series number 5 in basic arthroscopy by Dr. V.B. Bhasin, past president of the Indian Arthroscopy Society. It's on developing triangulation skills. It's on this coming Tuesday at 7 p.m. So please tune into the same channel for this live webinar. Thank you very much.